to the NEETPG 2025. Today I shall be discussing questions from renal and GI tract. Let's look at the first question. The first one says, the graph shows the renal clearance of 4 different substances. Which of the following correctly identifies the 4 substances? Now, if you look at the graph, there is plasma concentration on the x-axis and the clearance is given on the y-axis. The unit for clearance is ml per minute. Now, we know that the clearance of inulin is equal to the GFR. Why is the clearance of inulin equal to GFR? Because inulin is a substance which is freely filtered, not reabsorbed, not secreted. So the only mechanism by which inulin is removed from the plasma is by the process of filtration. Therefore, the rate at which inulin is removed or cleared from the plasma will be equal to the glomerular filtration rate. So, the GFR is 125 ml per minute. And as you can see over here, there is a green line or C, which is at 125 ml per minute. So this is the clearance of inulin. Now, all reabsorbed substances will have a clearance which is less than the clearance of inulin, and all secreted substances will have a clearance which is more than the clearance of inulin. Now, why will all reabsorbed substances have a clearance less than the clearance of inulin? Because reabsorption means re-entering into the plasma. So, volume of plasma free of that substance in unit time will start reducing. And similarly, secretion means from the plasma into the tubular fluid. So, volume of plasma free of that substance in unit time will now be more than the clearance of inulin. Now, if you look at substance D, now this substance below a certain plasma concentration has a clearance of 0. It is not cleared from the plasma. After a particular plasma concentration, the clearance of the substance increases but is less than the clearance of inulin. So it's definitely a reabsorbed substance. Now, this is going to be the clearance of glucose. Why glucose? Because below renal threshold, there is no glucose in urine. What is renal threshold? When the plasma concentration is below renal threshold, the clearance will be 0. Because the urinary glucose is 0. What is clearance? UV by P. If urinary glucose is 0, clearance will also be 0. But after the plasma concentration exceeds the renal threshold, now glucose begins to appear in the urine. So now the clearance of glucose will increase but will always be lower than the clearance of inulin because at least there is some reabsorption of glucose. Look at substance A. At low concentration, very high clearance. But as the concentration of that substance increases in the plasma, the clearance starts reducing. This is the clearance of para-aminohippuric acid. Para-aminohippuric acid in low concentration is freely filtered and completely secreted. So its clearance is very high. And the clearance of para-aminohippuric acid in low concentration is equal to the renal plasma flow. When the plasma concentration of para-aminohippuric acid increases, there is a partial secretion, incomplete secretion of para-aminohippuric acid, which starts reducing the clearance. But as you can see, the clearance is always more than the clearance of inulin because it is at least there will be some secretion of para-aminohippuric acid. If you look at B, now this has a clearance almost equal to the clearance of inulin, but slightly more. This is the clearance of creatinine. Creatinine is a substance which is freely filtered and slightly secreted. So its clearance will be slightly more than the clearance of inulin. So here, A is para-aminohippuric acid, B is creatinine, C is inulin, and D is glucose. So the correct answer is C. Which of the following decreases GFR? Increase in the glomerular capillary hydrostatic pressure. The glomerular capillary hydrostatic pressure, or PGC, is a force which is favoring filtration. So increase in PGC will increase GFR. Increase in renal plasma flow. More the flow into the glomerular capillary, more will be the glomerular capillary hydrostatic pressure, more will be the GFR. Increase in Bowman's capsule hydrostatic pressure. Bowman's capsule hydrostatic pressure, or PBC, is a force opposing filtration. So increase in this pressure will decrease GFR. Increase in Bowman colloid osmotic pressure. Increase in Bowman's colloid osmotic pressure, or PYBC, is a force which is favoring filtration. This will increase the GFR. So my answer to this question is C. Increase in Bowman's capsule hydrostatic pressure will oppose the filtration and decrease the GFR. The PCT has all of the following transport proteins: sodium glucose co-transport, yes. Sodium amino acid co-transport, yes. Sodium H plus counter transport, yes. It does not have a sodium bicarbonate co-transport. So answer is D. A 40-year-old patient with a history of gastrectomy presents with lower limb numbness. On examination, he has decreased sensation in both lower limbs and Romberg sign is positive. Deficiency of which of the following substance is the most likely cause of his symptoms? Of course, we know that B12 deficiency, thiamine, B6 deficiency, all of these can present with peripheral neuropathy. There could be a lower limb numbness, decreased sensation. But the moment we read about a history of gastrectomy, that points towards a B12 deficiency. Why so? Because from the parietal cells of the stomach, there is secretion of intrinsic factor which is required for the absorption of B12. B12 is absorbed in the distal ileum. So this is due to a deficiency of B12. Which of the following is not a mechanism of action of ADH? Increased water permeability in the collecting duct? Yes, this is an action of ADH. ADH increases the numbers of aquaporin 2 on the luminal membrane of the collecting duct cells. It increases urea permeability in the medullary collecting duct. Yes, this is also an action. It increases urea permeability in the descending thin segment is also one of the actions of ADH, though it has a moderate effect on the descending thin segment, but it definitely does not affect the sodium chloride reabsorption in the thick ascending limb. What is going to directly increase sodium chloride and potassium reabsorption in the thick ascending limb is the action of angiotensin 2. Not aldosterone. Angiotensin 2 directly acts on the thick ascending limb, increasing Na plus, K plus, Cl minus reabsorption. Aldosterone acts on the collecting duct. The formula for renal clearance of urea is UV by P. Clearance of any substance X is urinary concentration of X into rate of urine flow divided by plasma concentration of X. You have to keep in mind concentration is per unit volume. Rate is per unit time. So clearance of urea, U would stand for a urinary concentration of urea in milligram per ml. Concentration is always per unit volume. So it is not a urine volume in 24 hours or urine flow rate. Urine flow rate is V, or urinary excretion of urea. No, it is a urinary concentration in milligram per ml. All of the following increase gastric acid secretion except gastrin, yes. Histamine, yes. Acetylcholine, yes. Secretin decreases the gastric acid secretion. Please remember, all the small intestinal hormones will reduce the gastric acid secretion, not increase it. See, all the small intestinal hormones are secreted once the food reaches the small intestine. So once the food is in the small intestine, we need the gastric acid secretion to reduce and the intestinal and pancreatic secretions to increase. So secretin will decrease the gastric acid secretion. Migrating motor complexes occur every 90 minutes between meals. These are stimulated by motilin. Absence of MMCs will cause an increase in which of the following? Now, when I look at the migrating motor complexes, the first important point is they occur in the interdigestive period between meals. They are stimulated by a hormone which is known as motilin. Motilin is secreted by the MO cells. It is not a neuronal activity, it is a hormonal activity. What is a migrating motor complex? It starts as a ring of contraction from the body of stomach and it reaches right up to the distal ileum. So it's like a squeezing movement of the gut. It occurs, the first migrating motor complex is at least 120 minutes after the last meal, and after that it occurs in cycles of 90 minutes till you have your food. The moment you eat your food, these are gone. So what is the action of the migrating motor complex, or the function of the migrating motor complex? It has a clearing action. It removes all the food debris from the small intestine and pushes it towards the colon. These migrating motor complexes are also known as housekeeping contractions. Why so? Because they have a clearing action. They are known as hunger contractions. Why so? Because they occur between meals. Now, one of the very important functions of the migrating motor complex is that since they are occurring every 90 minutes, they ensure that there is no reflux of the colonic contents into the... Now, this is very important because you must understand that the colon is very rich in bacteria. If the colonic contents reflux into the ileum, they will colonize the ileum. And once they colonize the ileum, there are two very important substances which are absorbed from the distal ileum, that is B12 and bile acids. 90% of the bile acids absorbed from the distal ileum. So if the distal ileum or the ileum gets colonized by colonic bacteria, absorption of these two very important substances will be affected. So because of the migrating motor complex occurring every 90 minutes, this ensures that the flow is from the ileum towards the colon and not in the opposite direction. So if migrating motor complexes are stopped or absent, what will happen? There will be increase in the intestinal bacteria. Maximum frequency of slow waves. What are slow waves? Slow waves is your basic electrical rhythm. This is a variation in the membrane potential of the smooth muscle of the GI tract. It's sort of an oscillatory membrane potential. Sometimes this membrane potential is less negative, sometimes more negative, sometimes less negative. This oscillating membrane potential is known as the basic electrical rhythm or the basal electrical rhythm. And this variation in the membrane potential is generally between minus 40 to minus 60 millivolts, or some books say minus 45 to minus 65 millivolts. The amplitude of the waves is 5 to 15 millivolts, and the frequency of these waves is variable in different parts of the GI tract. The maximum frequency will be in the duodenum, which is about 12 per minute, and the minimum frequency is in the cecum, which is 2 per minute. Now please remember, the BER is not responsible for contraction. Contractions are produced by spike potentials which are superimposed on the BER. These spike potentials are known as the true action potentials, which are, like I said, responsible for contraction. More the number of spike potentials, more will be the contractile activity. BER is only a variation in the membrane potential. BER is also known as the slow waves. BER are produced by the pacemaker cells of the small intestine. Which are the pacemaker cells of the small intestine? The interstitial cells of Cajal or Cajal. So these are the slow waves in the GI tract. Maximum frequency, duodenum. Minimum frequency, cecum. In a clinical experiment, one group is given 50 grams of glucose IV, another group is given 50 grams of glucose orally. Which of the following can explain why oral glucose load is cleared faster than from the blood? Now, when we give oral glucose, There are agents which are secreted in the GI tract which increase insulin secretion, which are also known as incretins. What are incretins? These are GI hormones which increase insulin secretion. The most important incretin is GLP-1, glucagon-like peptide 1. This is known as the physiologic beta cell stimulating hormone of the GI tract. We know that today GLP-1 analogs are so much in the news. They've just been very recently introduced even in the Indian market. The other important incretin is GIP, glucose-dependent insulinotropic peptide. Now, why is oral glucose cleared faster? This is because along with the release of insulin from the beta cells of pancreas, GLP-1 also increases the insulin release. So, not just the release of insulin because of a rising blood glucose level, but also there is GLP-1 induced insulin release. So the answer to this question is C.